So I've been asked to talk about COPD exacerbations. If not, what else? I'm going to start with 3 cases, and I want everyone to kind of think about these cases as I go through my talk. We'll come back to them at the end and maybe have some discussion when the session's over. So first, you have a 65-year-old female that comes in. She's Gold E. She has frequent exacerbations. She has high blood pressure. She has heart failure with reduced ejection fraction. She comes into your ER, and she has increased shortness of breath, and she has a non-productive cough. She tells you that her symptoms worsened 4 days ago when the air quality index was in the red zone. So she was in Pittsburgh during the summer with the Canadian wildfires. And she was also last hospitalized with an acute exacerbation 6 weeks ago. Your second case, you have a 66-year-old male who's COPD. He does not have a history of exacerbations. He's Gold B. He's pretty well controlled on LABA/LAMA therapy. He does continue to smoke 1 pack per day. He comes to the ER and says for the past several hours he's had increased dyspnea, he's had some intermittent lightheadedness when he's been walking, and says this morning I coughed up a little bit of blood when I woke up. He's tachycardic and he's mildly dyspneic when you see him in the ED. And then finally, you have a 72-year-old who is also Gold E with 2 to 3 exacerbations per year, managed on triple therapy, going to pulmonary rehab, comes to the office with shortness of breath, some increase in a productive cough that's purulent, and says he's had chills over the past couple days. Okay, so before we talk about exacerbations, I think we need to take a step back and we need to talk about COPD as part of a multimorbid state. So years and years ago, we thought of COPD as a single disease. We were focused on the lungs. So there's an inciting factor such as cigarette smoke. It causes inflammation in the airways. It causes tissue destruction. This leads to respiratory symptoms. We perform spirometry and they have a reduced FEV1 to FVC ratio. Probably about 20 years ago or so, when I was starting my fellowship, we started to focus on COPD still as a single disease, but with comorbidities. So the thought then was that there is there's another inciting factor, cigarette smoke, there's inflammation in the lungs. This inflammation spills over into the systemic circulation, and it's a systemic inflammatory response that causes cardiovascular disease, osteoporosis, muscle wasting, neurologic disease. We've shifted our paradigm more recently even further, now considering COPD in the context of multimorbidity. So COPD is part of a multimorbid syndrome where you have a cluster of diseases that have a common shared risk factor, common underlying pathobiological processes that lead to a multimorbid state. So it's important to think about this when we're thinking about our patients that are presenting with an exacerbation and we're assessing whether or not this is really an exacerbation. Okay, so we know that multimorbidity increases with age, but it occurs earlier in COPD. So in this study that was conducted in a large cohort in Spain, they took over 27,000 individuals that were part of this cohort that had COPD, and they matched them one-to-one to individuals without COPD, matched for age and for gender. And what they did was, you can see in this graph on the top is COPD, the bottom is non-COPD. The bands represent the number of comorbidities, with the darker bands representing a higher comorbidity count, and the width representing the proportion of individuals within that age bracket with that number of comorbidities. And what you can see that over the lifespan, multimorbidity increases with age, both in people that have COPD as well as those that don't, but we're seeing this occurs much earlier in individuals with COPD. When they looked at deaths, they also saw that the death count was increased and it occurred earlier in individuals with COPD versus those without. So the comorbidities become particularly important when we ask ourselves, what do our COPD patients die from? So this is a study from the ERIC study, over 15,000 subjects. They stratified them by their obstruction severity. And as you would expect, those individuals that had severe obstruction, so Gold 3 or 4, a significant proportion of them died because of their respiratory disease, so because of their COPD. But they were dying for other reasons. They were dying because of cardiovascular disease, lung cancer. However, when you look at individuals with COPD that have less obstruction, so Gold 0, Gold 1, Gold 2, they found that although a small proportion did die from their respiratory disease, many more died from other comorbidities. And we know that multiple comorbidities are associated with survival in COPD. So Devo and colleagues published this several years ago, this concept of the comorbidome. So they took their cohort of over 1,600 individuals with COPD, and they identified 79 comorbidities in this cohort. And they developed this figure that you can see here, where they took anyone that had any comorbidity that had at least a 10% prevalence. They represented the comorbidity as a circle. The diameter represents the prevalence of that comorbidity. And there's the death star in the middle. And the closer the comorbidity was to this death star, the more highly associated it was with mortality. So any of the comorbidities that fell within that dotted line had a significant association with mortality. So common ones like coronary disease, congestive heart failure were strongly associated, but also more uncommon comorbidities such as esophageal cancer, liver cirrhosis were associated with mortality in their cohort. So in light of all this, you have to remember when you're assessing your patients that multimorbidity assessment is very challenging in COPD. So, and this is for several reasons. So it's difficult to assess multimorbidity in population-based cohorts. When we look at population-based studies, oftentimes comorbidities are, the prevalence is determined by self-report. So some of these comorbidities may be asymptomatic. So something like osteoporosis, someone can live with osteoporosis for quite a long time and they're not going to know that they have it until they have a hip fracture, or someone thinks to do a DEXA scan to screen for low bone mineral density. Symptoms may be attributed to underlying lung disease. So if you have a patient that has diabetes and they have ischemic heart disease that's undiagnosed, they may be just short of breath, and their physician may be attributing that to their underlying COPD. Screening rates are also variable with little guidance. So GOLD does a wonderful job at summarizing the comorbidities, talking about the importance of comorbidities, the prevalence, risk factors. But in terms of guidance on screening, it's recommended that we follow general screening guidelines. So if you look at general screening guidelines for many of these diseases, COPD is not considered a risk factor. Again, bone disease, if you go to the general osteoporosis screening guidelines, we know that COPD, particularly emphysema, increases risk of low bone mineral density, but COPD is not a risk factor to prompt early screening. So I think, when we're thinking of our patients and we're thinking about exacerbations, before we even get to the point of exacerbation, we need to take a holistic approach to their treatment. So we need to use tools for multimorbidity assessment during times of disease stability so that when they come to us with an exacerbation, we have a full sense of what is their multimorbid state. So there are many tools that we can use in our patients with COPD to assess for multimorbidity. There are simple questionnaires that you can use in the office to assess for depression or anxiety. We have low-dose CT scans in many of our COPD patients now because of lung cancer screening programs. You can look at coronary calcifications. There's technology coming out looking at things such as bone mineral density that can be automated and provided as a report. You can also do very simple functional measures in the office, things like sit-to-stand test or 6-minute walk test, to look for muscle dysfunction. So the GOLD definition of COPD exacerbation, coming to exacerbations, is increased dyspnea and or cough and sputum, less than 14 days. It may be accompanied by increased tachypnea and or tachycardia, and it's often associated with increased local and systemic inflammation that can be caused by many factors such as infection, pollution, or other insults to the airways. So when your patient comes to you with worsening dyspnea and they have COPD, you have to think outside the box. So it could be an exacerbation, but there are many other things that this could be. This could be cardiovascular disease. They could have heart failure. They could have an arrhythmia. They could have a pulmonary embolism. This could be infection, pneumonia, bronchiectasis. This could be comorbid lung disease in someone that has asthma and COPD, someone that has interstitial lung disease and COPD. It could be a flare of that comorbid disease. And then there are other things. So anxiety and depression can contribute to symptoms, pneumothorax, pleural effusion, anemia. So if not a COPD exacerbation, what else? And we're going to go back to the cases here. So again, COPD exacerbation, increased dyspnea, less than 14 days, tachypnea or tachycardia, congestive heart failure, a very common mimic of a COPD exacerbation, dyspnea, less than 14 days, tachypnea, tachycardia, PE, dyspnea, less than 14 days, tachypnea and tachycardia, pneumonia the same. So how do you sort this out when you're assessing your patient? So going back to our first case, a woman that has some cardiac risk factors, she's been exposed to pollution, she just had an exacerbation 6 weeks ago, she's now coming to you with increased dyspnea. There's a few things to think about with this case. Going back to multimorbidities and common risk factors, air pollution is certainly a risk factor for COPD exacerbations, but there's also very good data that it can be a risk factor for cardiovascular disease as well. So this was a study that came out earlier this year. It's actually a very powerful study. It was 3.7 million patients that were part of the Kaiser Permanente Northern California health system. And they entered into the cohort, they followed them for up to 10 years. They looked at annual mean PM2.5 exposure levels. And what was powerful about the study, instead of using zip code aggregated data, they looked at they geocoded individual address data. They also would follow them if they changed addresses and account for that. And they also had a lot of information on confounding factors, so BMI, smoking, comorbidities, and they adjusted for all that. And what they found was those that had long-term PM2.5 exposure that was high, that was associated with increased incident, acute MI, as well as mortality from both heart disease and cardiovascular, ischemic heart disease and cardiovascular disease. So, and what was really interesting in this study is those that had incident and acute MI, even with lower levels of pollution, they had an increased risk. This is another study that came out of Beijing, China, where they looked at admissions and admission days for cardiovascular disease, and they looked at heavy pollution and severely heavy pollution events of at least 1 day, and then they looked at hospitalizations surrounding those events. And what they found was for very heavy pollution events in blue and heavy pollution events in red, there was an increase in both cardiovascular disease admission numbers as well as days in this cohort. And we know that the risk of cardiovascular events alone are elevated following acute exacerbation of COPD. So again, if you go back to this patient, she had an exacerbation 6 weeks ago. This was a secondary analysis from the SUMMIT trial where they took patients that had COPD exacerbations that either had cardiovascular disease or had risk factors for cardiovascular disease, and they followed them up to a year. And what they found was those that had exacerbations, either all exacerbations or severe exacerbations where they were hospitalized, the risk of cardiovascular disease events was increased for up to a year. So this is something to think about in your patient that was recently admitted coming back with shortness of breath as well. Okay, so case 2. This is our patient that is having some shortness of breath, who coughed up scant amount of blood, who is having some lightheadedness and tachycardia. So things you're going to think about in this patient is potentially pulmonary embolus, and this is an important thing to consider in these patients. And the question is, do we scan everyone? Should we use an algorithm? So this is a study that looked at the prevalence of PE among patients with COPD that came in with acutely worsening respiratory symptoms, started with a relatively large number of patients. Because of different exclusion factors, they analyzed 740. And what they did for this study is they used a systematic approach to assessment. So first they looked at just the risk of pulmonary embolus based on Geneva score, taking into account the age, prior history, hemoptysis, vital signs. They gave them a score. If it was greater than 11, they were considered to be high risk for PE, and they sent them immediately to a CT angiogram of the chest. If they were lower with 11 or less, they sent off a D-dimer test. If that was high or they did not have a D-dimer for some reason, they sent them for a CT angio. And if that was low, they just observed them. And what they found was in the group that had a high Geneva score and they sent directly to CT scan, 29% of them had a PE on CT. And those that had a high D-dimer that were sent for CT scan, 7%. There were 11 that had low D-dimer that had a CT for some reason. They actually found that 27% of those also had a PE. So overall, PE was detected in about 5.9% of these patients within 48 hours of admission. So it's something that you need to keep on your radar. It's good to think about a systematic way of assessing these patients. And finally, case 3. So we have a 72-year-old with COPD, Gold E, 2 to 3 exacerbations per year. This is the one that comes in with chills, purulent sputum, suggestive of potentially pneumonia on inhaled corticosteroid. So as we know, pneumonia is increased with inhaled corticosteroid use. This is data from TORCH, where individuals were randomized to salmeterol, fluticasone, or the combination or placebo. And those that were receiving fluticasone alone or in combination, there was an increased risk of increase in pneumonia. In another study looking at types of inhaled steroids, what is higher risk, this is using data from the Quebec Health Records system, and this is looking at fluticasone and budesonide. They found that in this cohort, in this EMR-based cohort, that the incidence of severe pneumonia requiring hospitalization was increased in those receiving fluticasone, and it was a dose-dependent response. In budesonide, it was slightly increased, not as high as fluticasone, and it did not appear to be a dose-dependent response. And then in that same cohort, they looked at discontinuation of inhaled corticosteroids and found that discontinuation led to a 37% decrease in the rate of serious pneumonia. So steroids are good. Mark talked about inhaled corticosteroids, but it's just we need to be vigilant in not putting people that don't need inhaled steroids on inhaled steroids, and really thinking about this in the patient that does come in with pneumonia multiple times. Is there an alternative that would be better? So with that, just in conclusion, multimorbidities are common in COPD. They may be under or undiagnosed. We need to consider mimics of acute exacerbations, including congestive heart failure, PE, and pneumonia. And really, I think the take-home point is a holistic approach, not only to assessing exacerbations, but assessing these patients before they get to exacerbation is really critical to the care of our patients with COPD.